Okay, good afternoon, everyone. Thank you for the kind introductions. I'm Patrick KOR, Associate Professor from PolyU, and it is my honor to share with you about my latest project about the use of adaptive interventions for the family caregivers of people with dementias through a sequential multiple assignment randomized trial. We just completed the project recently, and it is a funded project by the HMRF in Hong Kong. So. Actually, the traditional psychosocial interventions are often static and one size fits all, but the caregiving for dementias is dynamic and the needs for the caregivers is changing over the time. So adaptive interventions are decided to specify when treatment should be modified for whom and for what alternatives should be offered for the family caregivers. And the use of smart design, we can allow the participant to be randomized more than once because in the traditional RCT, we just usually randomize the family caregivers into two groups, the intervention group and the control group. But when we use the smart design, we can depend on their response and further allocate the family caregivers into different groups depends on their responsiveness to the interventions. So this make them ideal for the complex psychosocial problem in the family caregivers, but not only for this population, but for also other psychosocial issues. So smart designs actually goes beyond asking, does the intervention work? Because in the traditional RCT, we usually ask whether the intervention is effective or not. We also calculate the effect size for the interventions targeting on the primary outcome. Instead, when we use the smart design, we ask what should we do next if the interventions does not work sufficiently. Let me take an example. If you feel headache, you may take the Panadol, but if the Panadol does not work, what will you do next? So smart design is a kind of is research approach to help us to think about what we should do next if the interventions do not work sufficiently. So using the smart design, we can evaluate the first line treatment options and also the response based on the treatment adaptation, and further whether to switch, continue, augment, or step down the interventions. And finally, we will find out the embedded dynamic treatment regime is more promising. So I will further explain the regime in the later slide in the methodology. So smart design is very suitable for developing the adaptive psychosocial interventions in different populations. So why we focus on these dementia caregivers? Actually, we find dementia shares caregiver, most of them are suffering from the depressions. In previous study, we found that 1 in 3 family caregivers experience clinically significant depressive symptom. And the depression actually is also associated with the poor caregiving well-being and also increased the healthcare use and also the premature institutionalizations of the care recipients. That means the older people with the dementias. And we found that the previous clinical trial or interventions, such as the use of mindfulness, demonstrate the benefits, but many of them are fixed dose and also single stage program. So that's why we want to develop an adaptive interventions for the family caregivers of the people with dementias because of the characteristic of the caregiving. It is not static, it is changing all the time. That's why we need to have an adaptive interventions rather than a fixed dose or a single stage program for the family caregiver. If you look at the literatures, we find that the most effective interventions for reducing the depressive symptom in the family caregivers are the mindfulness practice or mindfulness program, and also the behavioral activations. So these are two interventions adopt different approach. For example, the behavioral activations target on the active activities mode cycle. It can reduce the depressive symptom by increasing the contact with the meaningful and positive activities for the family caregivers. But for the mindfulness practice, the aim is to cultivate the present moment and also the non-judgmental awareness. It targets on the stress reappraisals process and also the ruminations in the family caregivers in order to reduce their depressive symptoms. So you can see these two interventions adopt different mechanism and also approach to improve the depressive symptom in the family caregivers. And many previous literature also show that their effect size on the family caregivers is moderate. However, how we should prescribe these two interventions for the family caregivers, what should be their sequence? Because both interventions in the previous literature also show the positive effect on the depressive symptom. So how we should choose the interventions for the family caregivers? You can see both of them adopt different mechanism, but but in previous study, even they have a moderate effect on the depressive symptom. You can see that some caregiver may also not being responsible in the respond to the interventions. In our previous study, we found that about 30% of the family caregivers still have a high level of stress and also depressive symptom after the mindfulness practice. Even we find that mindfulness practice has a moderate effect size on the depressive symptoms. So what we can do next if we find the family caregivers are not respond to the interventions, including the behavioral activations and also the mindfulness practice. So this is our major research questions for this SMART design. So in this SMART trial, we want to identify an optimal two-stage adaptive psychosocial interventions incorporating the behavioral activations and also the mindfulness practice for reducing the depressive symptoms among the family caregivers of the people with dementias. And we also want to know that which embedded dynamic treatment regime produce the greatest and also most sustained reductions in the depressive symptom. So what is the meaning of the EDTR, the embedded dynamic treatment regime? For example, in previous intervention, if we find that, for example, the mindfulness is not effective, we may increase the dosage of the mindfulness or provide them with some booster dose. So you can see increasing the dosage is a kind of regime for the non-responder. But at the same time, we can also switch the intervention. If you find that the family caregivers do not have any positive respond to the mindfulness practice, you can also further change and other interventions for them. So you can see there can be different treatment regime to reduce the depressive symptom in the family caregivers. So through this SMART trial, our goal is to find out the best embedded dynamic treatment regime, which can provide the greatest effect on the depressive symptom in the family caregivers. So we adopt the SMART design and also recruit the family caregivers from 3 community-based dementia service center in Hong Kong. We actually just finished the study and also finished the data analysis a few months ago, and the manuscript is just under review in JAMA. And in this study, we recruited about 230 family caregivers and register the trial in the clinicaltrial.gov. In this trial, our adaptive interventions last for actually 16 weeks. The stage 1 is last for 8 weeks. So that's why we have the assessment on the 8 week after the first day interventions, followed by the second stage interventions on 16 week. And then we will have the follow-up on 28 and also the 40 week. So for the inclusion criteria, we include the family caregivers who are aged 18 or above, and they provide unpaid care for the older people with dementias in the community, and they must need to provide the care for at least 3 months. We also target on the family caregivers who have already mild to moderate depressive symptom with the PHQ-9 score of 5 or above. So you can see our sample characteristic here. Majority of the family caregivers are age 60. That means most of them are the spouse caregiver, and about 74% are the female family caregivers. As mentioned, even the mindfulness interventions and also the behavioral activations, the evidence-based interventions, we find that in the stage 1, about only about 67 family caregivers are the responder. That means they have significant improvement after the first day interventions. And we found that 33%, that means 75 family caregivers are the long responder. That means they don't have significant improvement after the first day intervention. We could receiving the mindfulness or receiving the behavioral activation. So in the stage one, we adopt the traditional randomization method. So at the first stage, we randomize the family caregivers into the behavioral activation group and also the mindfulness group with the 1-to-1 ratio. In the behavioral activations, they will have 16 individual video conferencing sessions focusing on the technique of the behavioral activations. Each session lasts for 30 minutes, and twice weekly, they need to attend these behavioral activation training sessions. And the activities, including the including the activity monitoring, the goal identifications, activity scheduling, and also the barriers on the problem solving. So you can see the behavioral activation actually helping the family caregivers to better schedule their activity so that they will have more time to participate in in different social activities to reduce their depressive symptom. And for mindfulness practice, we adopt a similar dosage and also frequency, but the activities will be quite different from the behavioral activations. They will attend different training on using the learning the mindfulness through different practice, such as the body scan, sitting meditations, mindful movement, etc. The aim is to help them to cultivate the mindfulness attitudes in the daily life and also disengage with the negative thinking patterns that are harmful to their depressive symptom. So after the 8-week interventions, the caregivers will be classified as responder or the non-responder. So based on the respondent criteria, which is the 50% reduction in the PHQ-9 score from baseline, we will divide them into the responder and also the non-responder. For the responder, we will provide them the bi-monthly booster sections of the original interventions. That means they will not change to another interventions. They will keep the same interventions for the responder. But for the non-responder, we will further randomize them with the 1-to-1 ratio in two different groups. The first one is to continue the original interventions, but with some self-efficacy enhancement in the component. That means they will have the same modality, the same interventions, but we further enhance their self-efficacy in the same interventions, or they will switch to the alternative interventions. For example, the people join the behavioral activations will switch to mindfulness practice. The people join the mindfulness practice will switch to the behavioral activations. So based on this principle, you will see that we'll have 4 embedded dynamic treatment regime, including the behavioral activations. If they are non-responder, they will further receive the behavioral activations, but we further enhance their self-efficacy. For other non-responder, if they do not have any response to behavioral activations, we will directly change them to the mindfulness practice after the stage 1. And for mindfulness practice, if they same as the group 1, if they have no response, we will also add the self-efficacy component, and also further enhance their dosage of the mindfulness practice. And the last regime is to change their interventions to BA. So you can see in this study, we will have 4 embedded dynamic regime. So that's why we need to understand the 4 embedded dynamic treatment regime, because in the data analysis, we need to interpret the findings by comparing different grouping. For example, we want to know whether keeping the same modality will be better than the augmentations, or augmentations will be better than the cross modality switching. So you can see there are some regime here. BA changed to BA plus self-efficacy, and MP changed to MP plus self-efficacy. They represent the same modality continuation with the augmentation. However, the other arm will be BA changed to MP or MP changed to BA. It represents the course modality switching. So in this study, the primary outcome will be depressive symptom, but we further monitor their stress level, the positive aspect of the caregiving, the sleep quality, and also the quality of life. So we follow the intention to treat principle to do the data analysis. And the stage 1, we compare the BA and MP from week 0 to week 8, which is the stage 1 durations. And the EDTR analysis, we will also do the rating to estimate the regime level effect and further analyze the effects at stage 2 after the stage 2 interventions at week 16, and also the follow-up on week 28 and also 40. So from the stage 1 finding, we found that both BA and also MP produce significant effect on the depressive symptom by week 8. Both of them have similar effect size on the depressive symptom, and we find that there is no significant difference in the effect on the depressive symptom between the BA group and also the MP group. But for the effect size, we find that MP has a better reductions in the stress level compared with the BA. And we find that there's no significant stage 1 group differences for the positive aspects of the caregiving, sleep quality, and also the quality of life domain. And for the time by regime interactions for depressive symptom was statistically significant. We found that the course modality regime saw more favorable depressive symptom trajectory than the same modality continuations regime. That means we find that if there's non-respondent, it is better for us to change the interventions. For example, if there's non-respondent from BA, it is better for us to change them to the MP rather than increase the dosage and also give them some self-efficacy component in the interventions. We find that switching the modality is better than keeping them from the same modality in our smart design. This advantages was also sustained at the week 28 and also on the week 40. And for other secondary outcomes, such as the stress and also they also have the time by regime interaction effect. And we also find that changing the interventions from MP to BA can have a lower stress than other regime. And differences were also less consistent for positive aspects of the caregiving, sleep quality, and also the quality of life domain. And from the stage 1 non-responder, there are no significant difference effects on the depressive symptom across the 4 stage 2 regime. But we need to be cautious when we look at the responder and also the non-responder, we only target on the primary outcome. That means the depressive symptom. So you may argue that in the stage 1, some of them may already have improved in different secondary outcome, but for the switch and also the non-responder, we only target on the primary outcome of the depressive symptom. So so there may be some issue on the second outcome if we don't look at them in the treatment consideration. So in conclusion, we found that BA and also MP is very promising first-line treatment for the depressive symptom because of the moderate effect size on the family caregivers. Even they are very effective, we still find some non-responder in the interventions. And we also found that MP, the mindfulness practice, have an early advantage for the perceived stress reduction. That means in our algorithm, if the family caregivers have a high level of stress and also high level of depressions, they may more prefer the mindfulness practice compared with the BA. And we found that for the non-responder, switching to the complementary modality, that means switch their interventions may be more beneficial than continuing and also augmenting the same modality. So actually, this finding support us to develop a two-stage adaptive framework for the psychosocial interventions. So actually, in our analysis, we further analyze the algorithm by identifying some demographic data. So based on that data, we can identify or determine which caregiver should start with BA and which caregiver should start with the mindfulness practice. And after the first stage interventions, we can base on their response and then confirm to switch the interventions to the non-responder. So actually, this will be the next phase of our interventions. We will further develop these adaptive interventions and also evaluate the effects of this adaptive intervention using the randomized control trial approach. So that's all of my presentations. Thank you very much.